Welcome to 5 on Fridays. I'm Nathan Haynes, Chair of Paramedics Australasia in WA. I'm excited to bring to you a new project that aims to deliver evidence-based education from both a pre-hospital and in-hospital perspective. Each 5-minute video will form part of our continuing education program that will be presented from some of our leading practitioners from an array of specialties. On behalf of the West Australian chapter, I'd like to thank the chapter committee team, social media coordinator Chris Gray, and all those who have donated their time and expertise. I look forward to seeing you at one of our CPD events.
Hi, I'm Dr. Chris Armstrong. I'm an emergency registrar at Royal Perth Hospital, and this is 5 minutes on non-traumatic abdominal pain. So abdominal pain, really common presentation. It can go from the completely benign, needing almost no treatment, through to the very serious and immediately life-threatening. The cause is dependent on the site of the pain, and also depends on the ethnicity, the age and the gender of the patient. Upper abdominal pain can be caused by stomach or biliary tree or pancreas issues. And also remember, it can be chest issues radiating down, so don't forget to think about MI or pneumonia as a cause of upper abdominal pain. Central abdominal pain is usually caused by either a bowel or a vascular issue, and those two things can go hand in hand. So it can be something like a bowel obstruction, it can be an ischemic bowel, or the other thing that we have to bear in mind and be very suspicious of is whether this can be an abdominal aortic aneurysm. Lower abdominal pain, obviously usually caused by lower abdominal organs. On the right hand side, that might be the appendix. On the left hand side, that might be the lower bowel, for example, a diverticulitis. And if it's central, it might be the bladder, for example, a urinary tract infection. In women, we need to think about reproductive organs as well, so do think about ovarian or uterine pathology. Now, in older people, we have to be very suspicious of abdominal pain. Over the age of 65, it's rare to have a benign cause of abdominal pain, and so anyone who is older and is presenting to you, you need to be worried that there is something serious going on here. Now, the main thing that we have to worry about is whether this might be an abdominal aortic aneurysm. And classically, any older person over the age of 65 presenting with central abdominal pain radiating through to the back has an abdominal aortic aneurysm until proven otherwise. So what is an abdominal aortic aneurysm? Well, the abdominal aorta is made up of 3 layers. That's the intima, the media and the adventitia. The middle layer, the media, is the muscular layer, and that weakens as we get older, especially in smokers, diabetics and people with chronic hypertension. And it distends over the course of our lifetime. Once it's more than 1.5 times normal or greater than 3 centimetres, we call that an abdominal aortic aneurysm. Once it's above about 5 or 5.5 centimetres, you're at a rapidly increasing risk of it bursting or rupturing and causing sudden death. So how do we recognise these people? Well, classically, it'll be central abdominal pain radiating through to the back. Sometimes though, it can masquerade as a renal colic, so for example, a loin pain going to the groin, or sometimes even present with lower pains such as thigh pain or lower abdominal pain. Just remember, in an older person, just be suspicious. How do we assess these patients? Well, we need to do our standard observations, including our heart rate and our blood pressure. Remember that there will be no difference between one arm and the other in an abdominal aortic aneurysm. 85% of abdominal aortic aneurysms are below the level of the renal arteries, so below the kidneys, and so won't affect the blood flow through the subclavian arteries, which is what determines the blood pressure in both arms. They might be different if the person has a thoracic aortic aneurysm, but even then, not always, and it's not a sensitive test, so don't rely on that on ruling out an abdominal aortic aneurysm. Examining the belly, if you feel a central pulsatile mass, then that is an abdominal aortic aneurysm, and you need to get this patient to hospital as quick as possible. How are we going to manage them on the way? Well, pain relief is the mainstay of treatment in the back of an ambulance. If they're very hypertensive, we can think about giving them some GTN, and we certainly wouldn't intervene with low blood pressure until the blood pressure was less than about 70 systolic, or they were stopping perfusing the brain, for example, losing consciousness. At that point, we would give them some fluid. Once we get to the emergency department, what are we going to do? Well, we'll do an ultrasound to try and confirm that diagnosis. Sometimes we can't see it very well, especially in larger patients, and most of these, if they're stable enough, will go into the scanner and have a CT angiogram to confirm that diagnosis and aid us with operative planning. And we can repair these either with an open approach or an endovascular repair. So in summary, end of bed assessment, does the patient look sick or not sick? If the patient looks sick, then they probably are sick, and if they don't look sick, don't be fooled, it might be something serious and we need to prepare for deterioration if that's the case. Be suspicious of older people. Anyone who's over the age of 65 with abdominal pain usually has something pretty serious wrong with them, and especially if they've got risk factors, smoker, diabetic, hypertensive, and they've got that pain that's central and radiating through to the back. Be very suspicious of abdominal aortic aneurysm and get them to hospital as quickly as possible. That's your 5 minutes on abdominal pain.
you.